Good morning. Is the microphone okay? Can y'all hear all right? I do want to thank you for the chance to be here and to speak with you today, and thank Andy for his introduction, which was very generous. So I am a family practitioner. I worked in a small solo practice. My wife is a marriage and family therapist and a certified addiction specialist and worked with me. It was just the two of us. We had 4 employees. We had the same employees for 25 years. Most of them knew my patients' voices when they called up, and so they could triage. They knew who was really seriously having problems and who was not. And for many years, it was just a great model of a practice. Unfortunately, that model doesn't work much anymore. When it came to negotiating prices with insurance companies and stuff, it became more difficult to do that. So I think it's probably appropriate that I have morphed into this current job where I'm with the National Safety Council. I do still see patients 2 days a week in Western North Carolina. Now, a day and a half of that time is spent treating addictions, people that are addicted to opioids in particular. I work part-time at a methadone clinic and part-time at a Suboxone clinic. And then I spend one half a day at a mental health center providing primary care to severely mentally ill people. It's a semi-residential facility where they come during the daytime and they leave at night. Many of them are homeless. It's people with severe mental illness tend to die 20 years younger than the general population, so it's our goal is to try to get treatment available where they are so that we can help improve some of those rates. So in that capacity, I do still treat some folks with chronic pain. I do see that as a problem in my patients, but mostly I'm treating addiction nowadays. So I did want to say that as I talk, I can be very boring, so I encourage interruptions. If you have any questions, feel free, if I don't see your hand, shout it out. There will be time for questions at the end as well, as long as things go okay. But let's go ahead and get started. First of all, let me ask, how many primary care doctors do we have here? Quite a number. How many are most of you in outpatient practices? Okay, I see a lot of heads nodding. Okay. Again, my background being primary care, this will be to you folks a lot, but it does apply to hospital doctors as well. One of the things we struggle with in our practice are folks go to the emergency room or they're admitted to the hospital and they come out with prescriptions for opioids, and it can lead to some ongoing problems. So I wanted to start with a case presentation, and I actually stole this from NIDA, the National Institute of Drug Abuse. I don't know if any of you are familiar with their NIDA Med modules, but they have these continuing education modules that you can take and get credit, and in particular it's discussing the issue of drug abuse. And I use this for several reasons. One, it's a fairly typical patient, but also it really examples some of the common problems in our medical society today on how we picture pain and pain treatment. Even from NIDA, I think some of their conclusions are incorrect. So let's start out by talking about Joelle, an imaginary 25-year-old woman who sustained a third-degree ankle sprain in a motor vehicle accident. She was transported to a local hospital emergency department where she was treated. Her ankle was placed in a boot and she was given crutches. The treating clinician assessed the patient prior to prescribing pain medication. So look at these questions here. Which of the following would be the least important factor to consider before prescribing a pain medication to this patient? And I'll let you look at those and just think to yourself. So the answer is any history of concussion or traumatic brain injury. The other things are important to consider, and that includes cigarette smoking. A lot of people don't know that, but people that have been addicted to nicotine do have a higher risk of addiction to other medications and other substances, so they are at higher risk of developing problems on opioid medications. So the case continues. She has no history of substance abuse, receives a prescription from the ED physician. Notice it doesn't mention she has no history of mental illness. We'll assume she was screened for mental illness. Screening should involve more than just asking them if they have depression or anxiety, because many people don't know. But we'll assume she was screened for that. But it says she receives a prescription from the ED physician for a 3-day supply of acetaminophen and hydrocodone 4 times a day. 3-day supply, we'll assume she got 18 pills. 3 days later, she goes to her family practice doctor or her primary care doctor, and the swelling is reduced. She's maybe doing a little bit better. Clinically, the ankle is less swollen, but she's still having pain of 6 to 7 out of 10 and requests a refill on her Vicodin. So look at this. If you're the primary care doctor, this person's come to you, and I know you guys in primary care have seen this many times, a little bit different story, but very similar. Gone to the ER, got the pain pills, they're out now, they're coming to you, they're wanting more. So all of the following you should consider except which one? So let's do this one with raising your hands, if you will. What do you think is the least important? Is that what it's asking? All but which of the following issues? Yeah. Which one's least important to consider? The patient's current level of pain severity. How many think it's that one? Okay, I see one. The patient's age. How many think it's that one? Many more. Risk factors. Okay. And availability of non-opioid analgesic alternatives. I'm not real sure what that means. I mean, everybody can get ibuprofen and naproxen, right? So NIDA says the correct answer is the patient's age. My talk today is going to try to challenge that and see if we can change your opinion on that. First of all, a number of studies have shown that opioids are more risky in elderly people, maybe not for addiction purposes, but because it does increase their risk of falls. It causes cognitive problems. You know, if they're having some kind of borderline cognitive issues anyway, it can increase risk with that. You know, it might impair their driving. So it does affect older people more. So age is something to consider with this. Also, side effects like constipation are more likely in the elderly. So patient's age is something that should be considered. So NIDA goes on to talk, and I just copied this off of there, but I wanted to highlight a couple parts of it. They say prescription opioid therapy is indicated for pain that is moderate to severe in intensity and has a significant impact on function and quality of life. So they're saying because her pain was severe, or was moderate to severe, she needed another prescription for opioids. Now, the reference they have there is the Washington Interagency Guidelines from Washington State, and it actually is it's a paper or a protocol that's developed for treatment of chronic pain with chronic opioids. It's not to address acute pain. And also, theirs isn't quite so straightforward. They talk about prescription opioid therapy may be indicated for pain after other things have been evaluated and tried. NIDA also says here that opioids can be very effective for acute pain, but there's less data on the effectiveness of opioids for chronic non-cancer pain. Now, I want to challenge that also, saying that there is not much research that shows that they're that effective for acute pain either. You know, again, that's just kind of a common medical belief that we've been told forever, that these are good pain medications. You know, oftentimes they're referred to as powerful pain medications, but the science doesn't back that up, and we're going to talk about that in just a few minutes. It goes on, this is still in the NIDA module. It talks about risk of abuse. I wanted to kind of emphasize a few of these things. Prescription opioid analgesics are the primary treatment option for patients in pain. Again, common thinking, but that's what we're going to try to change, because that probably should not be the case. Talks about how the use of opioids has increased. We'll talk about that in a minute. Many health professionals are concerned. How many of you are concerned when you give someone a prescription for the opioids? How many of you does it bother a little bit? How many of you have known people like this lady where you gave it and they keep coming for refills, they run out early, and it gets to be a problem pretty soon? And they get to be real headaches in your practice sometimes, right? On the other hand, there's a lot of people that take them and 4 to 5 days later they're fine and you don't hear from them again. So some of the challenges we face are identifying those patients for whom prescription opioid analgesics may be the most effective treatment option. Number two, we need to identify patients who might require close monitoring. My belief is that that's everybody who's given a prescription for these, and identifying the subset of patients who might be abusing prescription opioid analgesics, including those prescribed by their clinician. So in 1997, this was a study by CDC. Prescriptions of opioids were prescribed at a rate of an average of 96 milligrams of morphine equivalent per person per year. So 11 years later, that had gone up to over 700 milligrams, and it's gone up since then. So think of that, 700 milligrams per person per year is how much we're prescribing and passing out to folks. That's enough to take a Vicodin around the clock for over a month, for about 5 weeks. But despite that increase in prescribing, this is from a study that was in JAMA a year ago. This is the Burden of Diseases study. And it looked at the state of U.S. health and how much disability we're having and years of life lost by disability. And as you look at this, these are all the pain-related ones: low back pain, other musculoskeletal, neck pain, osteoarthritis. You'll see that from 1990 to 2010, in each case, there's more years of disability for people, more years lost, more productive years lost because of disability from these pain-related issues over that 20-year period of time, despite the fact that we've increased our opioid prescribing by 600%. You know, you would think if we increased that much and if we worked that hard to treat people's pain, we'd be doing a better job, but that's just not the case. And I think those of us that have been in practice for a long time realize that we seem to be seeing more pain now than we were 20, 25 years ago. So the Institute of Medicine recently came out with a report, and many of you know about this, in 2011, the Relieving Pain in America report. And you know, their comment is that pain is rising. The prevalence of pain is rising. And why is that? You know, we lead easier lives. It's not like we're riding tractors and farming anymore. Our lives are much easier than they were 20, 30, 40 years ago, and yet our incidence of pain is increasing. And we'll talk about that in a minute, why that might be happening. But you know, this Institute of Medicine report is the one that said about 100 million people suffer from chronic pain in the United States. So, you know, about 1 out of 3, which is a very significant number. So there's some other things I want to address as we're talking about the opioid use and the numbers of opioids that we're prescribing these days. And that's one is the societal cost, all right? The cost to society of opioid misuse. Now this is not, this is talking about the abuse and misuse. It's not talking about just generalized use of the opioids, but the misuse and abuse. It's estimated to cost at least $55 billion to society per year. Now about half of that is to business and industry because of lost productivity, and you're seeing that more and more. I'm sure your employers are seeing that some in Dane County. I've heard that. I will tell you, throughout the Appalachian region, employers are not wanting to locate their businesses or their industry there because they have a hard time finding people that will pass the drug test to come to work for them. And once they do that, if they get on opioids, they have all kinds of problems with them. And so industry is a big part of that. You know, the medical field, people going to emergency rooms, overdoses, increased visits, all of that is a significant part of that. Law enforcement is a part of that. In my area of the country where I am, and I've heard this from the Dane County law enforcement people, the great majority of problems they're addressing, the calls they go out on have some relationship to the opioids. People robbing homes to get money so they can pay for their opioid addiction. So if you look at that $55.7 billion a year, that comes out to about $170 per person each one of us is paying because of the societal impacts of our opioid prescribing. And if you figure it out based on how much is prescribed, it comes out to 24 cents per milligram of morphine. So look at that at a bottle of Percocet, 5 milligrams. Now a 5 milligram Percocet is equal to 7.5 milligrams of morphine. And if you take 30 of those, the cost to society is $54. So any prescription, one prescription costs society that much money. You know, the folks go there and they pay, you know, their $3 copay or whatever it is, and it doesn't cost the pharmacy much, it doesn't cost the insurance company, but it's costing society $54 for each prescription. So I want people to think about that as they're handing out these prescriptions. This is a graph from the CDC also, and it shows the green line is the opioid sales since 1999. It shows how it's increasing. All right, right along with that and going along with that is the red line, which is the number of deaths from the opioid overdoses. And let me just say, you know, we talk about 17,000 people or more per year that die from opioid overdose, and that is a very conservative figure. Those are the only ones those are folks that are identified by autopsy, and you know, the drug tests come back positive and they've got no other explanation. You know, I will share with you again, in my rural county, it costs money to do an autopsy on somebody. If there's a 65-year-old who's found dead, if it was from an overdose or something, the doctor is going to sign off saying it was an acute MI. If he has any risk factors at all, that's what they're going to call it, and that's what it's going to be labeled. They're not going to do the autopsy. They're not going to pay the money for the drug testing. So it's considered a conservative figure, but you'll see that it goes up parallel with our prescribing. And then same thing with opioid treatment admissions, meaning the addictions rate is also going up. So the point of this slide is very important, showing that our rate of prescribing, our prescribing is the driver of this epidemic of opioid abuse and overdose. So Andy gave these figures when he was introducing me, and actually my figures are a little different because I use total overdose, which looks at other things in addition to opioids. But basically there's been a huge increase in just a few years, you know, and again, that comes as a result of the opioid prescribing. But it's affecting a lot of people here. According to CDC data, you can kind of get a reasonable estimate on how many people are addicting and how many people are taking it non-medically based on how many people are overdosing. And using their figures, you figure there's about 10,000 people in Dane County that are addicted to opioids, and there's about 60,000 that are taking them non-medically. And you know, I will promise you for sure with the 10,000, and maybe with these other ones, they're coming to your office in pain, all right? They're having the back pain, you know, whatever. They're telling you they need the opioids because that's the only thing that works for them. So to understand what to do about this problem and how to treat this problem, we need to understand pain. And you know, I think as a primary care doctor, I didn't fully understand this until I really got into doing more of this work. That pain really has two components, and this is from the International Association for the Treatment of Pain. A number of other pain organizations have very similar descriptions of pain, and the key is that it's an unpleasant sensory, so you're feeling the physical part of the pain, but it's also the emotional experience that goes along with that. And that's really key to understand as we're talking about how we're going to treat this pain. It's both of those. It's the sensory and the emotional experience associated with the tissue damage or whatever has caused it. So another thing to understand is that acute pain is different from chronic pain. All right, acute pain comes from acute injury. It lasts less than 3 months, usually considerably less than 3 months. Some people say 6 weeks on that, but most experts agree by 3 months all the healing should have occurred and the pain should be gone. Chronic pain lasts longer than 3 months. All right, and part of the reason that's important is because with acute pain, it's more of the sensory, the physical sensory of the pain, and it's not so much emotional. Whereas with chronic pain, it's just the opposite. You know, there's a physical part of it, but it's the emotional part that tends to be the part that really drives the pain and drives the behavior. So we need to realize that as people are going from acute to chronic, what is it that's driving that? What's the emotional issues that are doing that? Is it just the pain? Is it the other things in their lives? And we need to be addressing those issues more. So acute pain treatment, we're going to start by talking about that. That is really what I emphasize. Chronic pain is a whole different thing, and we'll touch on that at the end. But acute pain is the thing that hasn't really gotten much of attention on how we should be treating this. And there are several agents, obviously, acetaminophen, NSAIDs, opioids, topical agents, and physical modalities. We'll talk about those. First, acetaminophen, you know, it's been around for 120 years or something now. It certainly does have analgesic and antipyretic properties. It is available orally and IV. Is it on your formulary here, the IV form? It is. Is it used very much here? You know, it is proprietary, so I think it does cost a significant amount of money, which is one of the issues. Hopefully that won't last very long, but it is effective, used IV for various pain things. It does have minimal GI side effects, although there are some. It has been shown that it can increase risk of ulcers. And we'll talk about the number needed to treat. Number needed to treat is, a lot of this comes from the Cochrane reviews, and a lot of my data actually comes from Cochrane reviews. And let me just say, I kind of hurried up and put this slideshow together, and I didn't have my references on it, but at the end it'll have my email address, and hopefully all of you will have that. If you want references to anything I say, I've got data and articles that back all this up, and I'll be glad to send it to you. And the Cochrane reviews is one of the big ones that I use. So they're big on using number needed to treat. And the number they pick is 50% pain relief. How many people do we need to treat to receive 50% pain relief? And the reason they pick 50% is because the feeling is that 30% pain relief is a noticeable pain relief and people notice some improvement and it's significant. But you really need to get to 50% before you're increasing function in people. Before now they're getting out of bed, before they're going out shopping instead of staying home all day, you know, maybe getting back to work. So 50% seems to be kind of a critical level or an important goal to reach to show effectiveness that improves function for people. So we use the number needed to treat for 50% pain relief. For acetaminophen, for a 500 milligram pill, that's 3.5. So you need to treat 3.5 people for one person to get 50% relief. And again, with number needed to treat, obviously the lower the number, the more effective the medicine. The higher the number, the less effective. Now obviously the con is that there's no anti-inflammatory properties. Now the NSAIDs, they're analgesic, antipyretic, and anti-inflammatory. They're available oral, IM, and IV. The number needed to treat for 50% pain relief for a 200 milligram over-the-counter ibuprofen is just 2.7. So that's significantly better than acetaminophen is. And 2.7 is a pretty good number for pain relief. Now the cons are the side effects, the GI, the renal, and the cardiac in particular. You're all aware of those. We'll talk about those in a few minutes actually. The opioids, the pros, analgesic, it's available all different ways. Number needed to treat for morphine 10 milligrams is 2.9. So a 10 milligram injection, you have to give it to 2.9 people for one person to get relief. And as we go back, you look, 200 milligrams of ibuprofen was 2.7, you know? And again, this comes from Cochrane reviews that are looking at multiple studies and coming up with these numbers. So 200 milligrams ibuprofen is more effective than the 10 milligrams of IV morphine. And multiple cons. Mentally impairing. You know, they do impair. I don't know if any of you, if you give a prescription, if you warn people they should not be driving, but they shouldn't. It clearly slows reaction time. It slows judgment. One of the big things they've shown is that say someone's going down, they want to turn left. If they're on an opioid, they have a hard time judging if the oncoming car is too close or too far and whether it's safe to turn or not, and oftentimes they'll turn into somebody. So they are mentally impairing. Again, for the elderly, that can be a significant problem. The next thing, they delay recovery. How many of you were aware of that use of opioids delay recovery? You know, not many people are. Some workers' comp studies have shown that a prescription for an opioid after a workplace injury significantly delays recovery. And the thought is because of the way they work, people tend to, they're not as active afterwards, they're not as aggressive in doing their rehab, and it just takes longer to get better. It increased medical costs. It can increase medical costs 2 to 3 times. Opioid hyperalgesia is something that needs to be considered. There's some thought, there have been some tests that on medical students and college students where they test them with a pressure test with a blood pressure cuff, and they take it up to the highest level it can until it's not tolerable anymore, and they measure what that level is. Give them an injection of morphine, let it wear off, do that test again, and that number is much lower. So it doesn't take as much pain to give them a similar feeling that it's intolerable. It has been shown the longer we take these, the more likely that is to happen. Many people that fail opioid therapy or that are on chronic opioids, it's because they were given a prescription for back pain or whatever. It sensitized them to the pain. They felt the pain more as they tried to come off of it, and they developed this hyperalgesia. It's often confused with tolerance. It's hard to tell the difference sometimes, but it can be a significant problem and can really impair how we treat folks. A prescription for an opioid medication after a workplace injury, this has been shown again in workers' comp studies, doubles the risk of permanent disability. One opioid prescription within the 6 weeks of the injury doubles their risk of permanent disability. That right there, I think, is a factor that should make these relatively contraindicated after injuries. Again, they increase your risk of falls. There may be some cardiac and GI things. We'll talk about that if we have time. And of course, they can lead to abuse and addiction as well. And you know, I will share my patients I see in treatment, and I have about 350 in treatment in both my locations. Half of them, and I did a survey on them about 6 months ago, half of them got addicted when they were started on a legitimate prescription by a physician. And some of them said they knew right away that, you know, it made them feel different in a way that they wanted to keep taking them. Some of them did not. They just took them the way the doctor prescribed, but when they tried to come off of it again, their pain seemed worse, and it just led to a whole cascade of problems. So not everybody that gets addicted is because they started abusing, and many of it was with a regular prescription. So this is the number needed to treat graph that I did to look at different things. Acetaminophen, 500 milligrams on the left, you need to treat 3.5 people. Ibuprofen is better. It's about 2.7. Diclofenac, 100 milligrams, is better yet. It's down around 1.8. 100 milligrams of morphine, as I mentioned, it's up around 2.9. Oxycodone, 15 milligrams by itself, is not a very good pain reliever. That number needed to treat is 4.5. That's pretty significant. Ibuprofen, 200 milligrams with acetaminophen taken together, 500 milligrams of acetaminophen, 200 milligrams of ibuprofen has a very good number needed to treat at about 1.6. And as you see, it's better than 10 milligrams plus acetaminophen. That's really the equivalent of 2 Percocet pills. So, you know, again, 1 over-the-counter ibuprofen with 1 over-the-counter acetaminophen is significantly better than 2 Percocet pain pills for treatment of pain. And again, this is almost all from Cochrane reviews looking at these different issues. So we think about that and we think, okay, so for sprained ankles, you know, headaches, whatever it is, you know, maybe that's good. But for severe pain, we still need the opioids for severe pain. So this is another Cochrane review that looked at renal colic. And you know, we all learn in medical school renal colic is one of the worst pains there is, right? So they did a review looking at the different studies on this, and their conclusion was that NSAID medications and opioids have equal effectiveness in treatment of renal colic. And actually, as you read the studies they did, about 80% of them came to the conclusion that the NSAIDs were better. About 20% of them said that they were equal or that the opioids were better. But their conclusion was that they were essentially equal, but they said opioids have more side effects. More nausea and more vomiting, more impairment, whatever it is. So their recommendation was that NSAID should be used for renal colic. And I will share a personal experience. I have Crohn's disease. I get kidney stones periodically. I had one 6 months ago, went to my ER. They tried to give me morphine, 10 milligrams IV right off the bat. I told them I didn't want that. I wanted the ketorolac. They did that. Pain went away completely. My pain went from a 10 to a 0, in minutes. I told the doc I thought I must have passed the stone. It must be in my bladder. Did a CT scan. It was still impacted. Ended up having 2 operations after that to kind of fix the problems from that. But I never took an opioid the whole time. All right, got IV ketorolac in the ER, and I took oral ibuprofen and Tylenol afterwards. And it was a much better experience than I've ever had with kidney stones before when I got the opioids. So the severity of pain is not an issue. There's no evidence showing that the more severe pain need the opioids. And then just as we're talking about acute pain, some of the physical modalities, this is one that looked at heat and cold for low back pain, for acute low back pain, compared to just naproxen, which is the top line. Actually, it wasn't labeled. Well, it's not showing up, but the top line is just naproxen. The bottom line is naproxen with either heat or cold. The pain did go down faster with both heat and cold. So, temperature things help, range of motion stuff helps, some exercise, all that kind of stuff that we recommend for people. Again, with sprained ankles, she should be doing range of motion stuff, and bearing weight is tolerated. So there are some physical modalities we can't forget, both for treatment of acute and chronic pain. There's a number of issues we hear from the orthopedists that they don't like to use NSAIDs for people with fractures because it delays long bone healing. There's actually not a lot of data that supports that. There's a few animal studies that have suggested that. But there have been some studies showing that opioids also delay long bone healing, primarily, again, because people aren't getting up and are not as active. And, you need the activity to stimulate some of the bone healing as well. So, we don't know what to think about that. But there are a number of issues we still need to study. But again, in particular for someone like this Joelle that we talked about at the beginning, her initial treatment should have been acetaminophen and ibuprofen, a recommendation. Now, the problem is, and I know this as a primary care doctor, somebody pays money to come see you, they don't want a recommendation, they want a hard prescription of some kind. So, if they can tolerate a diclofenac. I will say that these doses we're talking about of acetaminophen and ibuprofen are very safe. Even people with mild to moderate kidney disease, with a history of ulcer disease, the rate of complication from 200 milligrams of ibuprofen 4 times a day and acetaminophen 500 milligrams 4 times a day is equivalent to placebo. So it's very safe doses at this. And the other thing, I don't want to go back to the previous picture, but it showed how effective the 200 milligrams of ibuprofen is. If you go to 400, 600, or 800, it doesn't improve the effectiveness that much. We're using too high doses of these medications sometimes. We can get by with much lower doses that are much safer for our patients. So for chronic pain, I did want to touch on a few things. Y'all have probably heard this. There's no evidence that opioids are effective for long-term treatment of chronic pain. You'll hear a lot about some of the studies, some of the medical education things like the SCOPE trial or the SCOPE study, not SCOPE study, the SCOPE training by Boston University, where they talk about safe and effective use of opioids for chronic pain. In reality, there's no evidence that it's safe. Now, it may be safer than how we're doing it sometimes, but it's still, my belief is, as long as we're prescribing a fair number of these medications, it's still going to be dangerous. And there's no evidence that it's effective. So, you'll hear, again, a number of, in particular, pharmaceutical companies will be saying safe and effective treatment. They like to kind of get that phrase out there. That just is not the case. No evidence that they can be used safely and no evidence that they can be used effectively. And here's an interesting thing, and I did get the reference for that, but again, I'll be glad to help forward these studies to any of you if you want them. Epidemiologic studies, this in particular was a large Denmark study that looked at treatment of chronic pain, and even comparing for levels of pain, mild, moderate to severe, people that were on opioids had a worse quality of life. They didn't have any improvement in pain relief, but they had a worse quality of life. And again, I think many of us in primary care have seen that. These folks that get on the chronic opioids, they're always worried about them. They're coming to you all the time. Their family members are worried. Their life begins to revolve around the pain and the opioid treatment. Whereas those that never get on them, they seem to do better. We can't forget the additional treatments for chronic pain. So, I do certainly think that there's an ongoing need for chronic pain specialists to help us out. It can be very time intensive in primary care. We're just not reimbursed for that. But certainly physical therapy that needs to happen. And I will say, I think part of the problem is that insurance companies have gotten to where they just want us to give a pill. They don't want us to do these other kind of things. So they might approve, 5 sessions of PT and that's it, where some people with chronic pain need ongoing treatment. But physical therapy is something that needs to be explored. Counseling can be very effective in chronic pain. Studies have shown that it can be as effective as any medications, and again, part of this is helping people deal with the pain so that they're not victims from the pain. They can have victory over the pain itself. It doesn't get rid of it, but they can learn how to control it and lead a worthwhile life with their pain. And I say that as my wife is a counselor who does a lot of that. It's important to treat mood disorders, again, because of the mental health aspect, the distress that goes along with chronic pain. That needs to be a very important thing to look at, to screen for mood disorders, anxiety disorders. Exercise can be very important, and that needs to be tailored, however, but even chronic arthritis pain has been showing that getting out and doing some walking actually helps in the long run. Acupuncture in some situations may be helpful. Amitriptyline, one of the best pain medications for chronic pain, low doses in the evening if people can tolerate it. I will admit it's a hard medicine for people to take, but it can be very effective, as well as the other medications like it. Duloxetine and all the other antidepressants, duloxetine has an indication, of course, for chronic pain, but evidence has shown that the fluoxetine and paroxetine and all the others probably have a similar benefit. And again, that's probably because it's addressing the mental health aspects of it. Gabapentin is one that has been used primarily in neuropathic pain, but can be used in other kinds of pain as well. The other anticonvulsants, Lamictal, also seem to be helpful in these. Don't forget those. The GABA system is the one where marijuana works, and it's the one where Valium works, so it does kind of calm you down a little bit as well. 125,000. That's how many people have died from opioid overdoses in the past 10 years. And if you look at that number, it's twice the number of American deaths in the Vietnam War. If we start to put in perspective the significance of this problem. The CDC does call this an epidemic, and they've made this one of their priority issues for this year, and we anticipate for next year as well. They call it an epidemic, and when you look at the epidemic, we, the physicians, are really the vectors. We're the ones who are spreading this with our prescriptions that we're writing, the medications we're passing out. So of all the epidemics, you think how hard it is to control Ebola or TB. I was dealing yesterday with one patient in my practice who was thought to have TB, signed out AMA from the hospital. They couldn't find him because he's homeless. Showed up in my practice, and they think he infected everybody. But anyway, there's so much other stuff that goes on with that. But for this issue, we're the vector. We can have complete control over what the outcome on this is. And the epidemic is completely reversible with a change of behavior that will, I believe, if we're prescribing more ibuprofen and acetaminophen for acute pain, or more NSAIDs for acute pain and less of the opioids, will result in better pain management and less problems overall. So as we go back and look at Joelle, I think I've been calling her Jolene, but it's Joelle. I just want to say, as we look at this, as we see patients like this in our office, as we see people like this, in our practice or in the hospital, hopefully we'll think a little bit differently. Instead of giving that first opioid, which probably increased her risk of disability and complications, we'll go with the non-steroidal anti-inflammatories and Tylenol. We'll encourage them, we'll talk to them about the dangers of the opioids and why they don't want to be on it. And when they come back, we'll talk again and try to avoid using these medications. So I wanted to kind of wind this up with a prescription, or with a quote from Franz Kafka: "To write prescriptions is easy, but to come to an understanding with people is hard." And that's the root of a lot of the problem. Is it takes time not to give opioids sometimes. We need to work on that.